So most common non-traumatic knee diseases are osteoarthritis, rheumatoid arthritis, reactive arthritis, gout, septic arthritis, and tendonitis. Now, which are the lab tests which we do basically? So as Metropolis, we have different panels. One of that is arthritis panel, another is rheumatoid arthritis panel, and another is for the psoriatic arthritis. So when we talk about arthritis profile, we have like CRP, ESR, CBC, CCP, ANA, uric acid, urine routine, ASORA. These are the different tests which helps to differentiate the actual reason for the inflammation, actual pathology associated with the inflammation. In rheumatoid arthritis, when we go, it's more about the autoimmune disease. So basically, we are going towards what are the reasons in the autoimmune panel where associated autoimmune diseases, disorders such as your lupus, or it can be Jordan, or it can be the rheumatoid arthritis itself without any other MTZDs. So to further differentiate them, we can have ANA, NX, DSDNA, or SM, RA, C3, C4, SSA, centromere. And for psoriatic arthritis, HLA-B27, though it's not a complete marker for psoriatic arthritis, but yes, we have different tests for that as well, flow cytometry, PCR, and microarray. Now, when we talk about this synovial fluid, it gives even more information because before taking any decision, it's important to know the exact reasons. So when we do routine clinical pathology, sugar, protein, cell counts, their DC, the gram AFB stain, then biopsy, cytology, the fungal stain, and important is polarizing microscopy as well. We do RA factor in synovial fluid as well. So these are the tests which are available in synovial fluid, which can help to differentiate the exact pathology, exact reason associated with the knee diseases. Now let's talk about the arthritis profile as such. So very basic is your CBC and ESR, which we always do, because in chronic inflammation, you will find low RBC. If you have infectious etiology, then you will have high RBC. And some of the arthritis medicines, they reduce the platelet count. So it's in terms of prognostic monitoring, when we talk about increasing, reducing the dosage, your platelet count monitoring is important. Your ESR is high in inflammation, which is non-specific, but it is used to monitor the disease activity. Similarly, CRP is also non-specific. However, it is used to monitor disease activity because, yes, the degree of inflammation is associated with both ESR and CRP. Uric acid, as we all know, it's increased in gout, and uric acid crystals, at times, uric acid may be normal in your serum, but still you might find it because it might happen that it may be on the borderline side, and we may not actually take the actions for that. But when we do the synovial fluid analysis, when we do the polarizing microscopy, we might find uric acid crystals there. But in majority of the cases, your uric acid will be elevated as far as gout is concerned. Then we speak about reactive arthritis. So it may be either post-viral or post-streptococcal. So when we talk about post-streptococcal reactive arthritis, in which ASO is very useful marker. Urine routine also helps us because in terms of your connective tissue disorders, as well as in lupus, where you have renal damage. So your RBCs and proteins are elevated. Now let's have some information, since the question came about the RA factor. So what RA factor helps in? So the majority of people with rheumatoid arthritis have a large amount of rheumatoid factor in their blood. About 20% of adults with rheumatoid arthritis may never have rheumatoid factor. So yeah, if you talk about the sensitivity, then up to 70 to 80%, I would say that that if the RA is present, then the rheumatoid arthritis can be diagnosed. However, in early cases of rheumatoid arthritis, the sensitivity is little less, because as you can see, only 17% of cases of rheumatoid arthritis can be alone detected by RA. So if RA factor is detected, then generally the patient has more aggressive disease. It is also followed in patients with Jorgen syndrome to predict the development of lymphoma. It is not specific, but it's also present in other connective diseases, infections, and autoimmune disorders. So as well as in 1 to 5% of healthy people as well. Now, presence of RF predicts radiographic progression of bone erosion, independent of disease activity. Now, these are other conditions like, as I told, Jorgen syndrome, vasculitis, cryoglobulinemia, chronic liver disease, sarcoidosis, malignancies. So these are some of the tests in which RA factor is positive. So would want to say that RA factor is very useful for arthritis. However, we have to always rule out other conditions which can be associated with increased RA factor. And this was the 2010 ACR EULAR classification criteria, which clearly mentions that you should have joint involvement, serology, acute phase reactants, and duration of symptoms. All this scoring, when the scoring is more than 6, then you should consider the patient can be having RA. So if you see the serology markers, they have RA as well as ACP, that is your CCP, anti-CCP. Similarly, some other acute phase reactants like CRP, ESR, they also play a role in as far as the classification is concerned. Now let's talk about the ANA, the autoimmune conditions. So the ANAs are basically the test which these are the group of antibodies that are found in most of the people with lupus and scleroderma, and it is also found in few people with rheumatoid arthritis. And these antibodies basically suggest that autoimmune illness may be present. Although many people test positive, but have very little evidence of serious illness. So I would say that ANA is present in 40% of patients with RA. So as we talk about RA, we have to do in conjunction with RA, ANA, CCP. All this test together will be able to help us give a more clearer picture. Now, when we talk about the specific anti-nuclear antibody test for SLE, anti-dsDNA, anti-SM, anti-ROSSA. So when there is systemic lupus erythematosus, we will definitely have other clinical picture, but this will be the definitive diagnosis as far as the knee pain and the autoimmune conditions are concerned. Similarly for scleroderma, polymyositis, Jorgen, and also the MCTDs. Now let's talk about anti-CCP. Anti-CCP has been a very promising marker as far as RA is concerned, and the cutoff above 17, which suggests a possibility of RA. And as with rheumatoid factor, some people with positive anti-CCP will not have RA, but this test is somewhat more specific. So specificity is around 97% for RA. However, sensitivity is still 65%. So when RA and CCP are combined, the sensitivity increases. But nevertheless, it's worth to say that both these markers are generally seen in comparatively a progressive disease. So early disease, you might not be able to detect as well as with this anti-CCP and RA. So it has to be done along with other tests to increase the sensitivity. And also there are new markers like RA33, which are about to come, which will also help in the early diagnosis before the erosive changes takes place. About 20% of RA patients are seronegative. So meaning that if they have a very low RA factor and very low anti-CCP, and they basically continue to come back negative, but they still will have the rheumatoid arthritis. So other tests are complement C3 and C4, because this test measures the amount of complement protein circulating in the blood. And they involve reaction of antibodies with the antigens, and they are most reserved for the diagnosis and monitoring of patients with active lupus. So the people with lupus, they have frequently lower than normal amount of complement, especially if the kidneys are affected. These are some of the acute phase reactants which are also used, because acute phase reactants, as we saw in the EULAR criteria, are used to basically diagnose the RA. So, complement, ceruloplasmin, haptoglobin, fibrinogen, then CRP, albumin, transferrin. These are some of the APRs. There are some very good updates in RA when I was referring to some of the articles. In general population, having a low LDL means having a lower risk for cardiovascular disease. But in people with rheumatoid arthritis, low LDL has been linked with unexpectedly high cardiovascular risk, which is a very recent study. It's called as a lipid paradox, and this is because of the oxidized LDL. So oxidation of LDL, which is kind of more harmful kind of a cholesterol, which is associated with your cardiovascular risk, which is high in the rheumatoid arthritis. So yes, cardiac monitoring also plays a very important role in the patient who are diagnosed with rheumatoid arthritis. Another disease which is associated with rheumatoid arthritis or interstitial lung disease, which is very common in RA. And obesity, high levels of CRP, poor functional status, and a strong history of smoking are associated with the same. Now let's go on to the next type, that is psoriatic arthritis. So as far as HLA typing is concerned, HLA typing, HLA B27 is very helpful in people with a form of spondyloarthritis, such as ankylosing spondylitis and reactive arthritis or psoriatic arthritis. However, it is also present in 8% of general population, including healthy people without spondyloarthritis. Then we have, when we talk about the HLA typing, we have HLA DR4, which is a genetic marker for your rheumatoid arthritis. So HLA B27 is not diagnostic, that is not a definitive test, but it can be used to diagnose or to rule out a disorder. So definitely you should include that in the panel when you are when you are suspecting that the pathology behind the knee pain is going towards psoriatic arthritis or the ankylosing spondylitis. Now the synovial fluid clinical pathology, when your serology, if they have limitations, so if you're not able to get it clearly, the clear picture from that, which in many cases with the advent of new test you will be able to, but still synovial fluid remains a very much helpful tool, especially when you talk about the cytology and the clinical pathology, because it can detect the microorganism. So if you have any infectious infections which can lead to the knee problems, that can be studied, and you can do a microscopy, or later you can do the culture as well. Now, RBC count may be high after traumatic injury and slightly elevated in patients with osteoarthritis. Uric acid, as we told in gout, glucose is that are lower than normal may indicate the infection. LDH level, which is an enzyme which is found in synovial fluid, may be elevated in people who have RA, infectious arthritis or gout. So LDH, which in synovial fluid is a very good indicator of these diseases. Protein levels are higher than normal, and they may indicate an infection. Now, when we talk about biopsy or cytology, basically, examination of synovial fluid, I think all the orthopedician will definitely know how the procedure is, and after skillful arthrocentesis, sample processing have to be followed swiftly, because synovial fluid cannot be effectively fixed due to its viscosity. So yes, pre-analyticals play a very important role as well as far as the synovial fluid biopsy cytology is concerned. The viscosity test and the cellularity assessment with particular reference to the neutrophilic granular site fraction, as well as the examination of native preparation of polarized light, are some specific steps in processing of these samples. They are very useful in autoimmune arthritis and arthropathies involved with crystals, and least often with tumors as well. Now with fluid biopsy, you can see that the WBC count itself can help to differentiate between the different joint diseases. Normal synovial fluid will be having less than 200. In RA, it can be ranging. Polymorphs, you will be seeing probably 65 to 80%. In tubercular arthritis, your lymphocytes will be on a higher side. Similarly, in septic arthritis, again, your polymorphs will be high. So the knee arthritis definitely can have a very better picture as from the synovial fluid cytology and biopsy. Another is definitely the category, the viscous, clear, colorless, how the gross appearance of synovial fluid is. That also helps in grouping the different characteristics as per the grouping of the synovial fluid. Gross appearance will help in diagnosis of different arthritis. Proteins, as you can see, the proteins also help in differential diagnosis. Normal synovial fluid will have around 1.5 to 2. If in traumatic arthritis, it becomes 2 to 2.5. It's very high in septic arthritis, that is 5 to 7. Also in tubercular arthritis, the proteins increases. So it helps in diagnosis there as well. And then comes your classic biopsy, where basically you have a histopathological examination. And as you can see, the stages for fibroid necrosis, pannus formation, glomerular synovitis, and then you can also detect the gouty arthritis. So yes, that remains mainstay as well as far as the definite diagnosis is concerned. But that's invasive because it involves an arthroscopy. But next is our polarizing microscopy. This is used especially for monosodium urate crystals in the synovial fluid. When we are, as I told you, we are not able to clearly distinguish from the serum test, then this test might be of very much use. For prognostic also monitoring also, I think, we can use a complete metabolic panel and sodium, potassium chloride, glucose, because for the prognosis, we have to monitor the renal conditions. We have to monitor the salicylates levels, aspirin, which is being given. And since Dr. Sabnis will be covering on the post-operative part as well, maybe, it's very important for a patient to maintain a steady post-op status. And for that, we do the routine tests, as we can all see here.